Good morning and welcome to this fourth session in our Dementia Reconsidered series. And today you're here to hear about using medications wisely. I'm so grateful today to be joined by one of my new colleagues at the Westbrook College of Health Professions here at UNE. Sydney is up on the Portland campus, so we don't have a lot of opportunities to interact. But I heard about a program she did on deprescribing. I know of her interest in deprescribing and was so glad when she agreed to join me for our program today. So you'll be hearing from her in the second hour. So I want to thank you for coming, but I also want to thank you in advance for what I hope will be your very active participation, which you will do primarily by writing into the chat box. I have about 30 minutes or 40 minutes at most of remarks. And as questions come up for you, please put them in the chat box. I'll be followed by Sydney, who also invites questions into the chat box. And then we will take all the questions at the end. And that way we will be able to have a really, I hope, robust conversation, if you want, about medication use in older adults who are living with dementia. And I thank you for everything you do in their care currently. I'm starting these days with a moment of silence, and how could I not after the year that we've been through? So if you will just join me for a moment, thinking about those patients, residents, family, friends, colleagues, whom we may have lost to COVID, whom we may have lost through violence, and even those who perhaps did not lose their lives, who have been affected by the pandemic. Let's hold them in mind for a moment as well. Okay, thank you for that moment of respect. So here's the spirit of today's training. I love this quote from Maya Angelou, who basically, when she was asked to write the sort of poem, I think it was for Clinton's first inauguration, she decided to ask this question: how do we want to be remembered? And she said, what I hope is that people will say of our time is that we did the best we could. We did the best we could with what we knew, but then when we knew better, we did better. And I love to open up to thinking about this because I know that we are all, one, working hard, doing the best we can with what we know. We're particularly doing the best with what we know in regards to caring for people who are living with dementia. But over the last decades, we have learned so much more about good ways to take care of people who are living with dementia that if you hear something new or have something old validated that is still relevant, I hope you'll use it. And I hope that as we all know better, we will do better. So here's the agenda, pretty straightforward. We're going to start with a poll. We're going to just do a little pulse check-in with how everyone is doing in our virtual community today. Then I'm going to talk about pharmacologic ways to address dementia, and I'll be followed, as I said, by Sydney, who will be talking about gradual dose reduction and deprescribing. So I'd like to start with a poll, and I will just have to find it here. As I'd like to know who's here. And here are your choices. We've invited people who are living with dementia. We've invited people who might just be interested in the area of medication. We've certainly invited all allied health professionals as well as prescribers, family members. In other words, we'd like to make this knowledge available to as many people who are interested in hearing about it. And so please check in with your primary way that you identify yourself. And give everybody a chance to check in and declare themselves. So really, really nice spread, which I will share with you in just a moment. All right. That's a minute. 80% of people have voted. I'm going to call it closed. And here's who's in the room together today. We have mostly, as we would predict, prescribers and allied health professionals, and a few other people, including students, who are learn what they can as well about medication use in older adults. The next thing I like to do in these virtual webinars is to just take the pulse of the room. So if I could ask you to type in the chat box one word that describes how you're feeling right now. You might be feeling happy, sad, tired, exhausted, overwhelmed, grateful, joyful, anxious, apprehensive, eager to learn, whatever it is. I'll let you go ahead and start chatting those in. And curious, content, busy, hopeful, busy, doing well. Glad to hear it. Glad to hear all these hopeful, happy to be here, stuffed. I won't explore that one further, Patty. I don't know if that's stuffed with knowledge or you just had a big breakfast, but excited to learn, eager, grateful, great. So it sounds like we're all in a pretty good headspace for learning. So without further ado, let me move us right along here. What I'd ask you to keep in mind when thinking about medications of any kind, we're going to be talking about meds in dementia. But, you know, when I think about what it means to use medication wisely, this is the kind of mantra that goes through my mind. I want to pick the right drug for the right reason, give it at the right time, at the right dose, and for the right person. And the reason I really want to make sure that we always bring our knowledge back to the individual patient, person, client, or resident is that we may have a drug that is known to work, a class of drugs is known to work for a particular condition. And we know in general what the dose range is for people of a certain age, people of a certain body habitus, perhaps, whatever it is. We know all of that in the general way. And that's our starting point. Like what should I be looking for here by way of medication? But at the end of the day, there is always a person on the end of that drug who is receiving that drug. And at that point, it is incumbent on those of us who are prescribers to make sure that whatever it is that we are prescribing or recommending have more benefit than harm. This is particularly true in the care of older adults, where really our first obligation is to not hurt people. And why do I put it like that? Because it turns out that about 80% of emergency room visits for older adults are due to adverse drug reactions, okay? 80%. If you're an economist, you look at that and say, well, I know how to reduce healthcare costs, keeping people out of the emergency room. If you're a person who's older, you're thinking, wow, I hope somebody's looking after my meds carefully so I don't fall and end up in the emergency room or have an adverse drug reaction. If you're the prescriber, I hope you're thinking the same thing. Have I given meds, either the right med to the wrong person, the wrong med to the right person, a drug in too high a dose or too many drugs at the same time? And at the end of the day, have I justified that this person at this point in time, the benefits of this drug outweigh the potential risks? Because all drugs have risks, drugs have side effects. And what we want to do in older adult care is to make sure that we're always on the right side of that equation, not doing harm, because it's easy to in the care of older adults. So when you think about dementia, here's what I would ask you to think about. First of all, dementia is not a diagnosis. Dementia describes a cluster of symptoms. It is a syndrome, and it has a cause. And it's always incumbent on us to find out what that cause is as our starting point and to make sure that the person's had an adequate workup. So as you know, the most common cause or type, as some people prefer to say, is Alzheimer's disease. It probably accounts for about 70 to 80%, either just being due to Alzheimer's disease or perhaps a mixed type with Alzheimer's and vascular disease thrown in. So our starting point is to say, what kind of dementia am I looking at here? What is the cause of this dementia? Because our choice of drugs will or should vary. Even the decision to use a drug should, or will vary depending on the type of dementia. So keep that in mind, number one. You got to know what you're treating. The second thing to keep in mind is that we actually don't have a disease-modifying drug. What do I mean by that? We don't have a cure for any of the dementias. We don't have a way to undo what's happening in the dementia, say due to Alzheimer's disease. It's even questionable whether or not we alter the course in any way. You know that a lot of ads for some of the drugs that are used in dementia care talk about slowing the progression of the disease. And it's one of those half-truths in my mind as I look at the literature. It is true that the drugs that we currently use, that we will be talking about momentarily, do provide symptomatic relief. And it is true that sometimes when people go off of their donepezil, let's say, they will get worse temporarily or over a longer period of time. So the takeaway on this is that we have to be honest about the relative value of the most commonly used drugs. The evidence really isn't very strong that we're modifying the course of the illness, though the evidence is stronger and still a little weak, that it provides symptomatic relief. So keep that in mind. When I talk about symptomatic management, here's really what we're going for in dementia due to Alzheimer's disease or some related disorder. The first foremost, I think, reason that we reach for medications is for cognition enhancement. When we talk about the cognitive symptoms of dementia, we're talking the ones that people most commonly associate with dementia, right? Memory problems, language problems, thinking problems, problems doing arithmetic, problem solving, executive function, all of those sort of cognitive aspects of the way the mind works. The other part of dementia, the other symptom, if you will, is the impact that a dementing disorder like Alzheimer's disease has on global function, has on the person's ability to do their regular activities of daily living. Those activities of daily living may be the most basic, like grooming and dressing and eating and feeding and attending to one's hygiene, using the bathroom, whatever it is. Or activities of daily living may refer to those instrumental activities of daily living that we need just to manage our lives, like going to the bank, mailing a letter, knowing how to call 911 in the course of an emergency, providing for our food, shelter, or clothing. So you have this sort of area that we simply lump together calling function, and we usually refer to that function in terms of the person's ability to carry things out independently or with minimal assistance. Finally, the last category of symptoms in dementia that people look to medications for are these things called behavioral and psychological symptoms of dementia, more often going by BPSD. And what people lump together in this BPSD category, you can see I don't know exactly what they stand for because I myself don't use it. BPSD is sort of behavioral psychological symptoms, I think is what it is. But its subcategories are sleep disturbance, irritability, agitation, apathy, anxiety, depression, psychosis. So it's sort of like everything that isn't cognition goes into the BPSD category. And this is the area where we have gotten into the most trouble using medications and using medications somewhat unwisely. So in the treatment of dementia, there really are these two sort of broad approaches, the use of drugs or pharmacologic approaches and non-pharmacologic approaches. And one of the problems, I think, with the way we have approached the treatment of dementia is as if it's an either or. You use non-pharmacologic, and if they don't work, then you go to pharmacologic. And you go to pharmacologic, and if they don't work, you go to non-pharmacologic. But actually, the treatment of dementia really ought to have, from the day the disorder is diagnosed, say Alzheimer's disease is diagnosed, it really ought to be from the beginning a both and kind of proposition in order to get optimal treatment of the symptoms of dementia due to Alzheimer's disease, vascular disease, Lewy body disease, dementia associated with Parkinson's, and so forth, FTD as well. Now, I debated with myself how much detail to go into here, and I'm not going to go into very much detail at all. But I want you to have an appreciation for what it is we're trying to do with medication in the brains of people who have Alzheimer's disease. There's a lot of work being done, as you probably know, on trying to understand the pathophysiology of Alzheimer's, what really causes it. But one thing we've known for a long time is that these brain cells or neurons that use a particular neurotransmitter, a particular chemical known as acetylcholine, are definitely important in learning and memory. And acetylcholine or cholinergic neurons in the brain definitely are impacted early on, say in Alzheimer's disease. They die off. And so there's not enough acetylcholine around, right, to fire the healthy brain cells that are still left. So if you're a drug maker, one of the things that you do is to say, is there another way that I can get more acetylcholine into the brain? So you have a few neurons die, maybe you can compensate with a drug that puts more acetylcholine in the brain. So ultimately, the way that was done was to develop these things called cholinesterase inhibitors. Because here's what happens. This is a little representation, obviously, of a neuron. You have an electrical impulse come down, right? It hits one of these little vesicles, shoots out some acetylcholine through this little thing called a synapse, picked up on the opposite side. It causes the next neuron to fire, okay? That's the way it's supposed to work. And it does work pretty well. After this chemical has done its job, it's usually broken down by an enzyme called cholinesterase. So if you wanted to have more acetylcholine in your brain, one of the things you could do would be to prevent it from being broken down. So we have cholinesterase inhibitors. And this has been the first really kind of successful class of drugs, and certainly the drugs about which we have heard the most. And I'm referring here to donepezil, which you may know more commonly as Aricept. Following on a whole decade of cholinesterase inhibitors, people began to appreciate their limitations, that it really didn't very robustly deal with the symptoms of Alzheimer's disease. It helped, but not very robustly. And so people started looking at other ways to impact nerve cells. And drugs like memantine were discovered. These are NMDA receptor agonists, to also have a positive impact on brain function. And so those are the two, because of their impact on the nerve cells. They don't actually release more chemicals, but they alter the way nerve cells behave. It's probably the easiest way to think about it. So what we have right now, just these two simple kind of schools of thought, are the drugs that you see on the screen here. Donepezil, most commonly known by its brand name Aricept, is the only drug approved by the FDA for all stages of Alzheimer's disease. But here's the thing for you to know. All of these drugs are only approved for Alzheimer's disease, with the exception of, I believe, rivastigmine, which may have FDA now for dementia associated with Parkinson's disease. Nonetheless, even though these drugs have only received their on-label indication for Alzheimer's disease, all of these drugs have been used with, frankly, minimal success in people with dementia due to vascular disease, frontotemporal dementia, Lewy body disease. And if you look at the literature here, you will perhaps be a little surprised to discover that even for those drugs that have been approved and that we use all the time, the level of evidence is actually pretty weak. And for those of you who are familiar with a particular website called Up to Date, if you want to make sure that your lit review is up to date, as I did, can find Up to Date online, is a really great way just to check in to see, what the latest is, if there's any new evidence, either strengthening our evidence for using these drugs or weakening it. And I have to admit, I was a little surprised to see just how weak the evidence is for using the drugs. It's there, but it's not that strong. I'm not going to read this whole thing to you, but I think what you can appreciate on the right hand is that the drugs that we prescribe for people living with dementia are not free of side effects, like any drugs aren't. And one of the things we have to really think carefully about, I think, with these cholinesterase inhibitors, particularly in the later stages of dementia, is whether or not for a given individual, the pill burden, the number of drugs they take per day, or the side effect burden is really worth it. If you have people in very advanced stages of dementia, for example, who no longer have any independence in any activities of daily living, meaning the most basic, and if your target symptom from the beginning was to give a drug that would support their functional independence, you're a little hard-pressed to justify the continued use of these cognition enhancers, as they're often called, in the later stages. And so those of you who work in long-term care, for example, or those of you who see people over a long period of time, may really want to think about not just when do I put a person on a drug, but when do you take them off? And to be a little more rigid, I think, or a little more careful in identifying the target symptoms before starting a drug. I think that for these cognition enhancers, we have focused for so long on the cognitive aspects that we have maybe not been as rigorous. I said rigid, but I really meant rigorous, not as rigorous as we could be in saying, am I really providing symptomatic relief in these areas where the patient and I agreed was our primary goal for starting a particular treatment? And that's what I mean about right, might be the right drug, might be the right dose, might be the right time, the right indication, and so on. But for that person, what symptoms are we targeting with that individual? What's most important to them? Because it helps us know when to start, what to start, but also importantly, when to stop. In the preceding slide, you saw a lot about some of the common side effects, nausea, diarrhea being two of the big ones. And truly, I have seen so many people living with dementia with poor appetites that are attributed to their dementia or not eating, their anorexia, their weight loss as being related to their ability to eat. But I think as often as not, it's because we have a whole lot of people with dementia walking around sick to their stomachs because of the drugs they're taking for their cognition. And so it really is incumbent on those of us who prescribe to make sure that we're giving more close follow-up than every 3 months or every 6 months, so we can really check in on whether or not any of those side effects are happening, whether a dose adjustment might help, whether taking the drug at a different time of day might help, whether taking it with a little food or not taking it with a little food will help. And that's what I mean about always bringing it back to that person and making sure that in addition to finding out if it's helping the symptoms, that it's not causing side effects. Because one of the problems for many people living with dementia is that they may not be as closely attuned to what's happening in their bodies. They may not have the words for it. They may not make the connection between the drug and the side effect. So for those of us who prescribe, we have to ask very specific questions to get at that information. There's also the problem, of course, of short-term memory loss or short-term memory loss, the person being able to actually both articulate the connection with their taking their drug and maybe having nausea and remembering it. So things like encouraging people and care partners to just keep it, particularly in the beginning of a new drug, a little drug diary, if you will, going over it with your care partner at the end of the day or at the time of taking the drug or an hour afterwards. Did I notice anything? Is this drug helping or hurting in any way? And here are some of the more serious adverse drug events that may result. And of course, the problem with bradycardia or a slower heart rate, and the problem with causing the potential for causing cardiac arrhythmias is a person can have syncope or fainting spells. And the thing that we always worry about with older adults and their blood pressure is having their blood pressure drop, or having a heart arrhythmia, having something cause them to fall, a fall leading to a fracture leading to a hospitalization leading to possibly surgery and possibly anesthesia and a post-anesthesia delirium and a marked worsening of their dementia. So this is where we take really great care. I'm often asked about the drugs on this slide as to whether or not they have any value. And the only one currently that, at least in up to date, they're recommending, I hadn't been doing this clinically, but that there seems to be some support for people who like vitamin supplements to supplement what they are taking with vitamin E. And that's a recommendation that, frankly, until I was preparing for today, I wasn't aware of. Over the course of my prescribing life, vitamin E has been in, then out, then in, then out, both as a prevention for getting Alzheimer's disease and then as a treatment for it. It looks like the available evidence around vitamin E is at 2,000 units a day won't hurt and might help. But I encourage you to look at that literature for yourself as well. And that's it on what we have to offer on cognition and global functioning. And now I'm going to suggest to you that you look away from this screen. We've been at it almost 30 minutes. Look out your window, stand up, stretch, take a break. This is how to help your brain avoid Zoom fatigue. Okay. What I want to talk about now are the BPSDs, the biological, the behavioral psychological symptoms of dementia. Throughout all of my career until about a decade and a half ago, behaviors were exclusively talked about as being symptoms of Alzheimer's disease or vascular dementia or FTD. So any behavior that occurred was seen through that medical, biological, symptomatic lens. Then I'm referring here to hallucinations, to delusions, to apathy, to irritability, to aggression, to agitation, to all of those things that we just call behaviors. Walking about, when you are bored, got called wandering, then it got called exit seeking. So we have pathologized a lot of simple human behavior. Over the last decade and a half, it's very clear that the new thinking in dementia is to say that there's more going on here than just symptoms. In fact, what's clear that it's going on is that behavior in all of us, but particularly in people living with dementia, perhaps, behavior equals communication. All behavior has meaning. These are not just symptoms of some underlying dementing disorder. If you hear nothing else today, please hear this. And so our first question, when confronted with a challenging behavior or psychic distress, is to ask, what does it mean? All behavior has meaning. What is this person to tell me? What can I understand here? Not, how do I get them to stop this distressing behavior? How do I get them to stop this behavior that challenges me? That's seems to challenge them. This is really important because I think this is one of the breakthrough lenses. It's not new, it's a decade and a half old, but I'm not sure that everyone really appreciates what it means in terms of our prescribing habits. Because when we thought of behaviors as symptoms, we have, 3 decades worth of history of reaching for a psychotropic drug from column A or column B or column C before ending up at the antipsychotics. So in the beginning of my career, which now spans 40 years, we used a lot of anti-anxiety and mood stabilizing drugs. Some people used sedative hypnotics, with the benzodiazepines, and what a disaster that was. Lots of people used Depakote, carbamazepine. Lots of people used antidepressants. And then antipsychotics became a kind of drug of choice, partly because some of the behaviors seen in dementia are psychotic symptoms, hallucinations, seeing, hearing, tasting, feeling, seeing something that isn't there is a hallucination. Delusional thinking, fixed false beliefs, those are psychotic symptoms. And in people living with schizophrenia, for example, or bipolar disease with psychosis, they work really pretty well. Antipsychotics target psychosis, and they're pretty good for that. But in people who have psychosis living with dementia, they actually turned out to do quite a bit more harm than good. And I'm going to talk about that in a moment. But when you see something, and this is really, really, sort of an occupational hazard, I think, for a lot of prescribers. When you see everything as a symptom, then of course, and you use medications as part of your toolkit, if you will, part of your way of managing, of treating, you reach for a drug. If something's a symptom of something, you reach for a drug. We have a certain conditioning towards that in our training. So we have to step back from it and think, are there additional ways or other ways that we can treat things? But when there were symptoms, we reached for symptomatic relief. And as a person whose career actually sort of moves right along our knowledge, I can tell you that in the beginning, because so much of what we were seeing in dementia looked like anxiety, it made some kind of sense to use anti-anxiety drugs. When we appreciated that people living with dementia due to Alzheimer's disease had a certain amount of lability, a certain amount of unpredictability, it made some sense to use mood stabilizers. Everything that we did made some sense because there is no anti-agitation drug, there is no anti-aggression drug. And so we're always looking for off-labels. Nowadays, these are the drugs that are very popular, antipsychotics that are very popular, used to treat BPSD, seen as a symptom. And you're very familiar with these drugs. The bold ones are the ones for which there is some limited data about their efficacy. All these on the list, though, belong to what are called the second generation or atypicals in antipsychotics. Since 2005, the antipsychotics have carried a very stern, very clear black box warning, pointing to the fact that antipsychotics increase mortality and the risk of stroke in older adults with dementia, and for whom these drugs are being used for what's thought of as a dementia-related psychosis, okay? That black box warning was there in 2005. And in 2005, between 2005 and 2008, when the next black box warning came out, saying, you know what, it wasn't just first generations, it's also second generation antipsychotics. Sales of antipsychotics had soared. So you get your first black box warning and they point the finger at drugs like Haldol and risperidone. So quetiapine makers get busy, blitzkrieg the whole country. And before you know it, Seroquel is being given to scores of people, despite the fact that there was a black box warning about antipsychotics. So it came out again in 2008, came out again in 2012. And the FDA, or the CMS said, look, There are only a handful of diagnoses that are actually approved for these. And when you are using an antipsychotic or any drug in an off-label way, it's incumbent on you to make sure you have a really good reason and that you're not going to do more harm. The problem with antipsychotics is that even though it's okay to use off-label in general, it's not bad medicine, that risk-benefit equation is more critical. And knowing that antipsychotics increase both the risk of mortality and stroke should give us a lot of pause about whether or not we want to use antipsychotics. To my mind, the other problem with antipsychotics is that it also misses the point. If behaviors are communications as well as symptoms, then treating something before you know what it means may in fact preclude your ability to get to the bottom of the symptom, if you will, or to get to the bottom of understanding the distress signal behavior. And the side effects from these drugs are considerable. They cause sedation and falls and stiffness and difficulty walking. But to me, in working with people who have dementia, the most important thing to them is to preserve what cognition they have, and antipsychotics accelerate the decline. So we work at cross purposes when we're giving cognition enhancers and at the same time antipsychotics for BPSD, because we are accelerating one symptom in order to treat another, and we don't have to. So my bottom line on antipsychotics, they don't work very well. The data is clear on that. They make people feel really lousy, and they kill some people. CMS made reduction of off-label use, as I already mentioned, a national priority in 2012, and a partnership came up of culture change coalitions all around the country, AMDA, all of the American Healthcare Association and state associations. People really came together, and I thought it was great that CMS said, you know, we're not just going to go the punitive route of tagging people if you prescribe drugs that we don't think are appropriate. We're actually going to have a national education campaign and teach you alternative ways to provide person-centered dementia care, because person-centered dementia care reduces reliance on antipsychotics. So far, so good. At the beginning of this initiative back in 2012, I happened to be living in Vermont at the time, and Vermont and Maine were in the bottom 10 of poor performers. In other words, we had a lot of people in both of our states, in Maine and Vermont, who were being prescribed an antipsychotic without, or an off-label antipsychotic without an appropriate diagnosis. We had a lot of people with dementia. And both of our states got busy. And we were among the first states to join the top 10 of high performers by reducing reliance on antipsychotics in this core population. And I really credit folks in Maine, particularly the Culture Change Coalition here and the partnership here to reduce inappropriate antipsychotic medication, as Maine did a phenomenal job. But something has happened since 2012, and after several years, actually, of having really wise use of antipsychotics across the state, Maine has now slipped back down to where it was in 2012, and now ranks near the bottom of antipsychotic use in the country. Our average use in Maine is 19%. Let me put that in a more, like in a plainer way. That's about 20. So about 1 in every 5 long stay residents in a Maine nursing home are receiving an antipsychotic without an on-label indication, okay? 1 in 5 are receiving it. But here's the interesting thing in Maine. We have a really widespread. In some nursing homes in Maine, less than 1% of their residents are on antipsychotics. And in other nursing homes in Maine, almost half are. And this isn't to point the fingers at anybody. This is just to say, take a look. Have you noticed an uptick? This data, by the way, is from the second or third quarter of 2020. This is publicly available data. It's published every quarter on the CMS website. And it really is just I share it here to say, take a look if you work in long-term care and see if you've had, kind of without even being aware of it, an uptick in the use of antipsychotics. And if so, how you might want to go about thinking about how that happened, how to make sense of it first, and whether or not there's something that needs to be done about it. The way I would say to start is just to look at all your residents who have an off-label use. Take a good look at their records and make sure that that even if it is an off-label indication, that there's a good reason for it and that good reason is documented, and that gradual dose reductions are being attempted. CMS requires that they be tried twice a year. And then look for some evidence-based approaches to gradual dose reduction to actually getting people off of them. And in doing that, you're going to be working with your medical director and primary care providers and pharmacists to guide that process. Dr. Springer is going to have a lot more to say about this in the second hour, so I'm going to let her take it from there. I'm often asked this, well, I hear all that and I realize there are risks with these drugs, but sometimes they're needed. So a reasonable question is it ever okay to use medications, including antipsychotics? Of course. All medication prescribing is about risk-benefit. It's all about looking at the person and seeing what would be most helpful to them. So it's okay to use medications for the right person, at the right dose, at the right time, for the right reasons, and that reason is really clear, and that decision to use a medication is part of an individualized care plan where the person living with dementia and their care partner, if they have one, have an opportunity to weigh in on that decision. The benefits have got to be greater than the risks. And then finally, there has to be no better alternative, because we do have many non-pharmacologic approaches. So before you use a drug off-label that has high risk, that has known high risk, and makes people feel really lousy, you want to try some other things first. One of the most important things that we've learned, I think, in the last decade is, we've relearned it really, is the importance of doing good pain assessments and making sure that we give a trial of non-narcotic, prophylactic, scheduled dose pain medication for people with extreme, or not extreme, but for people with agitation, particularly verbal agitation, calling out, who may or may not be able to point to pain as a source. And the same true for other directed behavior, often described as aggressive behavior. What we think right now is that some cognition enhancers, that those memantine for later stages and acetylcholinesterase inhibitor drugs may help some with apathy and depression. SSRIs may help with irritability. But the may there is really important. One of the other big problems in these drugs is that they get started and never stopped. So if you have a drug with a low probability of working, but you want to try it and the patient wants you to try it, it's really important to find out what the target is and then to watch. And if it's not helping, discontinue it. And each drug has its own period of time for how long you want to try it, right? Before you decide that it is or isn't working, or you need to adjust the dose. Antipsychotics have a focused and really limited role. Short-term treatment with risperidone to help severe aggression that puts a person at risk of harming somebody else or in extreme psychic distress is okay. It's okay to use it, but never for more than 12 weeks. The problem is people get on these drugs and stay on them. There is no current support for using trazodone, valproate, or carbamazepine, even though they remain really, really popular. So if you're thinking about using antipsychotics, that plan of care is important. Assessing the condition, checking for pain, trying other alternatives, document, involve the family, involve the resident, use absolutely the lowest dose. Monitor for the effect and for side effects, review it at 6 and take them off at 12. For completeness in your slides, I've included a list of non-pharmacologic management approaches, but I'm not going to go through them now because I want to make sure that we have plenty of time for Dr. Springer. But I include them because we've covered them in our other series, and I'm happy to answer any questions about any of these as well when we get to our Q&A. Here are some resources for you that I would also encourage you to take a look at from ACA and NCAL. I think the one that didn't make it up here is the AMDA site, the American Medical Directors Association, now called, I think, Post-Acute Long-Term Care Association, PALTC or something like that. Okay, here's how to connect with Aging Maine. Like us on Facebook, follow us on Facebook. Come and visit our website for additional resources. And now, while Dr. Springer is getting ready, I encourage you to take a 1-minute stretch break, step away, look away, and get ready for some additional learning. Thanks for your kind attention.
I love that presentation by Susan. I think it so nicely touches upon how complicated dementia care really is, and it's not as easy as starting a medication and going from there and hoping for the best. It's a complicated process, and something that I want you to come away with from my side of the presentation is we can be more active in the process. We can be more active in stopping medications that cause more harm than good. We can be more active in our knowledge, in our conversation with patients about medications. So I want to start off, Susan started off with a really lovely quote by Maya Angelou, and I'm starting off by a quote from retired pharmacist, Doug Danforth. He said, starting medications is like the bliss of marriage and stopping them is like the agony of divorce. And as someone who has neither been married nor divorced, I can't say whether or not this is true, but I will say that starting medications is the easy part. And then stopping them is absolutely terrible. It is a difficult process. And for some patients, it's this beautiful, easy, simple process. But for the vast majority, it's incredibly complex. There's a lot of psychological and social components that go into medication management. And I consider deprescribing a huge part of medication management. And so I hope to make this process a touch easier, because while I started off with this idea that it could be agonizing, I want you to leave knowing that you have a few more tools in your toolkit when you leave this presentation. So deprescribing, many of you have probably actually heard of deprescribing. Occasionally I use the word and people have no idea what I'm talking about. And sometimes I just assume deprescribing, if you break it up, it's just unprescribing. But actually it's got this very nice definition. It's the systematic process of identifying and discontinuing, and I've also added reducing. Reducing also counts as deprescribing medications in instances in which the existing or potential harm outweighs the existing or potential benefit within the context of a patient's individual care goals, their level of functioning, their life expectancy, their values, and their preferences. And so Susan has already highlighted how important it is to weigh the risk and benefit and keep in mind the right patient and the right drug and the right dose at the right time. This is just the definition of that. And deprescribing is just the process of recognizing when harm is outweighing benefit, and now we need to stop or reduce. So I'm going to start with some resources for both the community and the nursing home setting, so you can kind of use them interchangeably, but I'll show you when you can or cannot use them. So the classic tool that everyone uses in geriatrics is the Beers criteria, the most recent of which just came out in 2019. I do like to highlight, however, that while the Beers criteria presents medications that are potentially inappropriate, that should potentially be discontinued, reduced, or avoided altogether, they do make the designation that we really don't want to include those patients who are on hospice or palliative care settings. And so for our patients who have severe dementia, they may be on hospice or have palliative care, in which case we can't just say the Beers criteria says we have to stop using these medications. We need to recognize that the specific scope at which we look at medications changes when we're looking at patients who now the focus is not curative, but is more treatment-based, more focused on treating in the moment, short-term effects, and focusing on quality, not quantity of life. The stop-start criteria is one that whenever I teach my students about, they're always like, I've never heard of this. It doesn't make any sense. So the stop-start criteria is actually a very long document. It's over 50 pages. The appendix is that includes all the drugs with the actual drugs to stop and start. But it came out of Ireland. The most recent version was from 2012, and I am not sure if they're going to create a new version anytime soon, but version 2 came out, again, 2012. And it lists all these drugs that we should consider stopping or starting in our older adult patients. And what is so nice about it is that it's not this long process of huge evidence-based approach of reducing. It just focuses very nicely on, here's what we recommend, stopping this specific drug or this drug class in this specific patient population for this particular reason. And then they just cite their sources and kind of let you go on with your day and look at those sources on your own time, which as busy clinicians, a lot of us struggle with reading long guidelines that can sometimes make you question everything that you know about drugs. So the stop start is a really nice criteria for that. It's mainly focused on older adults in the community, but it can certainly be used for those who are in nursing home settings and can be used technically in the palliative care setting. You have to, of course, use your clinical thought process here, your clinical decision-making to determine if the criteria actually fits or does not fit. In 2017, the same criteria group came out with Stop Frail. So they specifically looked at drugs that should be stopped in those who are frail with limited life expectancy. And so they created a list of 27 drugs that are included here that should be stopped in this particular setting. So this is just another tool for your medicine bag for you to think about. In my particular patient who might be frail with limited life expectancy with dementia, what medications should I be thinking about stopping? And so this goes really beyond the scope of the presentation. I want to focus on medications that really focus in on dementia or cognition, but this is a nice tool for just reviewing and thinking, is my patient on all the appropriate medications? Because so often in our patients who are on hospice or limited life expectancy, they end up dying with medications that serve no benefit in the short term. Medications that prevent heart attacks when the patient only has 2 months to live, or medications that are used for osteoporosis when the patient is bedbound. These medications have tons of side effects and drastically impact quality of life. And so this tool can really be used to assess what medications should I be thinking about reducing in most of my patients that fit this criteria. So today, like I said, the scope is really going to focus on medications for deprescribing that are related to dementia and or cognition. And in many cases, the conversation about cognition and dementia, of course, come together for obvious reasons. So I'm going to talk about anticholinergic drugs, benzodiazepines, antipsychotics, and anti-dementia medications, all in the scope of deprescribing. So firstly, we have anticholinergic drugs, and for the purpose of this presentation, I don't think it makes sense for me to go deep into their role. They have limited roles in certain settings. They can be used for allergies, thinking of antihistamines. So drugs like loratadine has a little bit of an anticholinergic effect, whereas a drug like Benadryl has quite a strong anticholinergic effect. Parkinson's disease drugs like cogentin, that's a common anticholinergic drug that we use in Parkinson's disease. Urinary incontinence drugs, for the most part, most act on are antimuscarinic and have anticholinergic properties, hence why they're able to work for urinary incontinence. You're trying to reduce that symptom. And so we'll see in a second that they do a good job at doing that for the most part. And then psychiatric disorders. So a lot of antipsychotics actually have anticholinergic properties to them. And so I think about drugs like clozapine, quetiapine, and olanzapine. Those all have a little bit or a lot, depending on the actual drug, anticholinergic effects. And then there's a whole slew of other medications that are anticholinergic. Muscle relaxants that we use so often have anticholinergic properties. Tricyclic antidepressants are very anticholinergic. And some benzodiazepines can actually be anticholinergic in nature. And the reason that we worry about anticholinergic drugs is so manifold. They have so many side effects. And when I'm teaching about anticholinergics, I like to say these are our dry drugs. They cause dry mouth and constipation, blurry and dry eyes, and urinary retention. But then on the other end, we can get overheated. We have difficulty sweating. So again, drying up. But we have drowsiness, dizziness, confusion, and then our cardiac symptoms like rapid heart rate are not uncommon with anticholinergic drugs. So there's a lot of reasons why these drugs are hard on the body. And so some of you are thinking, well, okay, but I've been on an anticholinergic drug and I haven't had these symptoms. And really what we know is that older adults tend to experience these symptoms much more than younger adults. They are much more vulnerable. And the reason being is that the blood-brain barrier permeability changes with age. So a perfect example is that first-generation antihistamines, like Benadryl or Clortab, are very clearly associated with passing through the blood-brain barrier and causing cognitive impairment and cognitive side effects. And second-generation antihistamines are associated with less of this. However, they do still pass through the blood-brain barrier, and you still get some anticholinergic side effects. As we get older, we actually get more susceptible to these anticholinergic effects because of this blood-brain barrier permeability change. Our metabolism slows or delays. We have reduced elimination of drugs because our metabolism and excretion change, our renal function changes. We have differences in our cholinergic transmission. So when Susan was talking about the typical transmission of acetylcholine through the synapse, that changes with age too. And then of course, when you're on more drugs, the likelihood that you have more drug-drug interactions goes much higher. It's much higher really quick. I like to say it's exponential. So adding one drug, no drug-drug interactions. Adding a second drug, potential for risk. Adding 3, 4, 5, and up to 10, 15, 20 we see in older adults. The probability of a drug-drug interaction increases exponentially with each added drug. So what is the evidence? So anticholinergics are associated in worsening cognition in essentially any older adult population. It doesn't matter where they're living. So this affects all of us wherever we're working, wherever we're caring for people. Anticholinergics are also associated with delirium. So if you have a patient with dementia, an anticholinergic should absolutely be removed from the medication list. Patients who have comorbid psychiatric conditions are much more vulnerable to these side effects, and it could be a combination of physiological changes, but it could likely be related to the drugs that they're already on if you have a comorbid psychiatric condition. And I wanted to mention here, because we'll talk about it a little bit later, up to 50% of those who are on acetylcholinesterase or cholinesterase inhibitors for dementia are taking anticholinergic drugs. So our anticholinergic drugs are commonly drying. Our cholinesterase inhibitors are commonly our wet drugs. So it's very common for what we call a prescribing cascade to happen, where a patient says, hey, I'm really feeling sick, I'm feeling nauseous, let me add on a drug for my nausea, like meclizine, maybe you're having vertigo, and now I have an anticholinergic drug on board. Or let's say you have urinary incontinence from your cholinesterase inhibitor. It's not uncommon for someone to add oxybutynin in order to reduce their urinary incontinence. So 1 in 2 of your patients who are on cholinesterase inhibitors are likely to be placed on an anticholinergic drug, which completely negates the benefit of the drug. And I like to mention this here separately, is that these anticholinergic properties are cumulative. The longer we use these drugs, the more likely we have side effects. So chronic use of anticholinergics is associated with a reduction in mini mental state exam scores. So as that score goes down, the likelihood of dementia increases, right? So our cognition is reduced. And incident dementia. So in these studies that I'm mentioning here, we're talking about 6 years of cumulative use is associated with reducing your MMSE and increasing your risk of having a diagnosis of dementia. And so you're thinking, well, if my patient already has dementia, what's the problem? Going back to our other problem, which is now we're increasing their risk of delirium. And these effects are cumulative. Again, and really the evidence for discontinuation is conflicting, and it's not because when we take off the drug, we don't expect to see a little bit of benefit. but it's the deprescribing studies right now are just so lacking in quality of study, in design, in really reducing cognitive anticholinergic burden. So I think right now we're not clear if you stop the drug, do you improve the situation? If you stop an anticholinergic drug when someone is delirious, you do decrease their risk of having delirium, and that delirium should improve as the drug comes off. But whether or not it impacts their likelihood of having dementia is not yet well known. Anticholinergics are also associated with worsening functioning, physical functioning, mortality, and hospitalization, which we've already learned our patients with dementia are at a high risk of. Older adults in general are already at a high risk of hospitalization due to medications. Anticholinergics, a big cause. So one tool that you can use is the anticholinergic cognitive burden scale, the ACB. And so while it's small here, I'll try to send it out later to the group. You guys have it available to you. This is something you can fold up in your pocket and just say, is my patient on one of these drugs? Really what we're looking at is scores 2 and 3. Those are the ones with pretty much definitive anticholinergic burden associated with them and anticholinergic properties. So if your patient is on a score 2 or 3 drug, those drugs need to be considered to be removed, ideally. And what we know about this is that as the score increases by 1 on the ACB, so it's cumulative, if you have a drug in score 1, a drug in score 2, and a drug in score 3, your total score is 6. For every score increased by 1, your MMSE goes down by 0.3 points. So we know that these medications are associated with reduction in cognition on objective tools. And so you're thinking, okay, well, now I know I need to stop these drugs. How do I stop them? Well, there really isn't a lot going on for how to stop it. And it's the best evidence I could come up with was from New South Wales. They have a really great Deprescribing catalog. And so they go a little bit more beyond Deprescribing.org, which we use all the time for deprescribing some medications. And I'll show you resources from Deprescribing.org shortly. But really what we want when we're thinking about deprescribing anticholinergic drugs is thinking, okay, what is the actual reason they're on it? If they're on it for Parkinson's, we need to monitor very specifically for worsening movement changes. If we're thinking about anticholinergic drugs for urinary incontinence, we're now worried about if the incontinence reappears and that quality of life associated with worsening incontinence, if it does get, in fact, worse. For the most part, when it comes to how to reduce, we're talking about a 25% reduction every 1 to 4 weeks. And you're going to notice that I say that term a lot, 25% reduction over 1 to 4 weeks. And that's just because we don't have clear-cut guides on how to stop a lot of medications. And it's mainly because we don't have a lot of trials to say, is this the safe way to do it? Is this the wrong way to do it? So for the most part, reducing is better than not. And what I like to do when patients are on anticholinergic drugs is I just reduce the dose to the next possible dose available. And I just check in 4 weeks and say, how do you feel? If it's incontinence, I'm asking about symptoms of incontinence. And I'm trying to think, okay, is this significantly worse than it was before or about the same? With incontinence, I'm also thinking, how can I add on things like Kegel exercises if our patients are comfortable doing those kind of things or can learn from physical therapy, for example. So checking in is number one. So I'm going to move on now to benzodiazepines because there's actually some kind of conflicting data around benzodiazepines, but for the most part, there is some good data to show that we really need to avoid these drugs if we can and stop them if we possibly can. So when it comes to benzodiazepines for insomnia, this is where I think we see benzodiazepines more commonly now, but actually benzodiazepines improve sleep by about 10 to 15 minutes. They improve the quality of sleep, but not the quantity of sleep. And they diminish usually around 4 weeks in terms of efficacy. So about at 4 weeks, we're seeing a kind of a stunting of the improvement of sleep. And now they're really just helping you feel like you're sleeping better, but you're actually not. And the worst part about this is that our REM sleep, our good deep sleep, is impaired by benzodiazepine use, and the adverse effects persist. So if you have a benzodiazepine on board for insomnia, you get very little benefit for sleep, and you mostly get side effects of falls, changes in cognition, like I'll talk about, fractures, and the feeling of being hungover the next day. There is really conflicting evidence around whether or not they're associated with dementia or cognitive impairment. A 2016 meta-analysis and systematic review of almost 4,000 patients found a pretty strong association between benzodiazepines and dementia in patients who were on them chronically. So there is some newer evidence saying, okay, we are seeing a signal here. There may be a risk of dementia. What we do know is that patients who are on benzodiazepines experience memory loss. They experience confusion and disorientation much more than on placebo, or what we commonly expect amongst our patients who are not on benzodiazepines. And benzodiazepines are associated with retrograde amnesia. So when you take the drug, you forget what's going on moving forward. And that effect is persistent. So if you consistently take that drug, the risk of retrograde amnesia exists every single day you take the drug. So it does make sense here when we think about biological plausibility that benzodiazepines would be associated with cognitive impairment. And so that evidence is more unclear right now, but it's moving in the direction of we think that there's a risk here. And of course, if you have a patient who has dementia and who's on a benzodiazepine, you greatly increase their risk of delirium. And that kind of goes without saying. They're deliriogenic drugs, absolutely. So who should be deprescribed? And what we know so far, this is basically based on studies that have been deprescribing successfully. So chronic insomnia management, anything over 4 weeks, we need to consider deprescribing. And the rationale behind that is there's just no benefit. Like what I said, there's very limited benefit. Cognitive behavioral therapy is significantly better than a benzodiazepine. And there's just more side effects. Additionally, if you have a patient who is being managed for anxiety that is otherwise controlled on, say, long-term therapy, so they're on an SSRI or another antidepressant agent, or they're participating in cognitive behavioral therapy or another type of therapy, and they're successful in that process. They're going to each session, they're learning coping mechanisms, and they have improvements objectively and subjectively in their anxiety. These are patients we can deprescribe. There is, of course, limited evidence in patients who have, let's say, the limited, restless leg syndrome, uncontrolled anxiety, depression, physical or mental conditions causing or aggravating insomnia, and then alcohol withdrawal. So those are the patients we might not touch our benzodiazepines on, but the other two groups, we absolutely have a reason to deprescribe. So again, how do we deprescribe? Well, one is if we're thinking about management of anxiety and insomnia, cognitive behavioral therapy is the best treatment for both. So with that being said, while I'm the pharmacist, I still recommend and I refer my patients to social work, to counselors, to have cognitive behavioral therapy if they possibly can, to our psychologists as well. So how do we reduce the drug? Well, we typically reduce by about 25% every 2 to 4 weeks. And I will say that I tend to go on the lower end of this, especially with our patients who are on chronic, long-term benzodiazepines, high doses, multiple times a day, which is what I'm seeing a lot. I will say a lot of folks might feel comfortable switching to a long-acting benzodiazepine and then reducing the dose from there. There's no evidence to say that switching from a short to a long-acting benzodiazepine is appropriate. And actually, I think it makes it more difficult to deprescribe because it's such a different drug quality in the body when we go from short to long-acting. And older adults tend to do worse on long-acting benzodiazepines. In terms of monitoring, again, every 2 to 4 weeks, I have patients that I monitor every single week in the very beginning when I'm very nervous that we're going to have rebound symptoms of insomnia and rebound anxiety symptoms. And I'm worried if they're not, actively engaged in therapy or being managed otherwise. Withdrawal symptoms I don't see as much, but we do want to worry about our gastrointestinal symptoms, irritability, and sweating. All of which do go away within a week or two of getting on each lower dose. There is, of course, what everyone will bring up is the risk of seizures when we withdraw. Really, we're rarely seeing seizures. If we see them, it's because a drug was abruptly stopped or they were on really high doses of benzodiazepines when they were abruptly stopped, or they have an underlying seizure disorder, and that is what precipitated the seizure and not so much just the act of stopping the benzodiazepine. A slow taper will reduce all of these symptoms of withdrawal. And so I wanted to mention here the Empower study, which was a Canadian-based study that looked at community pharmacies as a place to reduce benzodiazepines, specifically for the purpose of insomnia for the most part. But a couple patients in there were on it chronically for anxiety. And really what we know is that simply sending out this flyer, and I'm going to show you examples of it shortly, can actually really help us reduce our benzodiazepine use, can reduce and discontinue. And so in 6 short months, 27% of participants who received this simple intervention actually stopped their benzodiazepine altogether. And then another 11% of them within that 6 months who were in the intervention group reduced their dose, which is huge, thinking how hard, can you think of a patient where it was very difficult to stop a benzodiazepine? This is an incredible feat. The number needed to treat here is 5. You need to give 5 people this flyer to see one person stop a benzodiazepine in 6 months. And you may be thinking, well, my patients with dementia who maybe are in the care facility, this isn't for them. This can be used for a caregiver as well. And I've done that. So I used to work in geriatric primary care. And so I printed out this Empower sheet, which I'll show you in a second, for all of my patients and all of their caregivers, just for them to review. And I would just hand it to them and say, let's talk in a month. And almost 80% of the time, the discussion on deprescribing came back up because now we have some more thoughts on it. So this is what it looks like, the main page we have here. You kind of get this big sheet, and number 1, the first page is, you may be at risk, and it's this big, large font. And underneath it'll checkbox what benzodiazepine you're on to show, we're thinking about the drugs that you're on specifically. Then it has the participant go through a set of quiz-like questions. So true or false questions, very simple. Is my medication safe for the long period of time, true or false? The dose I'm taking causes no side effects. With the medication, I will be unable to sleep or will experience unwanted anxiety without this medication. And other questions like, the medication is the best available option for my symptoms. And the actual packet will then have them test their knowledge after this. And review. It'll have, for each specific question, it has some evidence-based approach that is in the format for the average older adult reader with a 6th grade reading level. And so other questions to ask yourself. So now this isn't so much testing your knowledge, but let's say, have you been taking this for a long time? Do you feel tired during the day? Do you have that hungover feeling in the morning? And do you have any problems with your memory or balance? And it goes in to say, these are side effects of your drug. And so it really allows the patient or the participant to walk through the brochure and learn a little bit and get a little bit more insight into how they are using their benzodiazepine and what potential risk it's posing. And what I love and hate about this is that it offers a tapering program. So based on how you're taking the medication, it'll say basically on week 2, on Monday and Friday, you half your daily dose and you'll take the regular dose on the rest of the days of the week. And then you start halving more days and halving every day. And then you start quartering your dose until you're essentially taking no drug. And so for the most part, I don't follow this to a T. What I typically do is I recommend small dose reduction. So if I have a patient who just takes it at bedtime, I recommend halving the dose closer to this particular schedule. But if I have a patient who's taking it for anxiety and is ready to come off of the drug, I may reduce 1 dose during the day and then do that for a week. And then I'll reduce a 2nd dose during the day and continue that for another week or 2. And there are patients who I have to reduce 1 dose a day a week for weeks before I get to the next dose and so on. So what I'm telling you here is that this is so incredibly, it can be time intensive, but if you let the patient tell you how they want to do it, they can actually create the schedule for you. And because there is no evidence-based specific deprescribing protocol, that is perfectly fine. Any way you want to get your patient off of the drug slowly is appropriate. And so the Deprescribing.org algorithms I mentioned earlier, we don't have them for anticholinergics, but we have them for benzodiazepines. And so I'm not going to take you through this entire thing. I just want you to be aware of them because they're so easy to read and they're meant for clinicians, but they have a ton of information on deprescribing.org that's meant for patients and their caregivers. And it's not uncommon for me to print out this algorithm and show my patients, this is what I'm going to do. Why don't you take it home and think about if you feel like you'd be comfortable doing this. Because I think it's so important at the end of the day with deprescribing for you to have your patients drive deprescribing. Ultimately, deprescribing done too quickly or not with your patient's best interest in mind. So going quickly for them to get off of a drug because you're more worried about getting off the drug than you are about their symptoms when they get off of the drug. And I know that our audience is not that group of people you're here today. But that can ruin your relationship with the patient, and it can ruin your ability or your interest to ever reduce these drugs again. So that's why I really focus in on the patient being the driver, and I give them as much information as I possibly can because the information is power. And the Empower study named it well. By giving your patients information in their hands to make the decision to stop on their own or to stop with the addition of a caregiver and make that decision on their own, you empower that person to reduce if they so choose and do it at their comfortable level. So now we're going to move on to meds that are really focused on dementia and behavioral symptoms. So antipsychotic medications come up, and I'm glad Susan had a really good review of them, so I can kind of breeze through some slides and then focus a little bit more on others that I think are going to be pertinent. So antipsychotics they have a role very specifically in patients who have schizophrenia, schizoaffective disorder, bipolar disorder. These disorders listed here, there's certainly a risk there. There's certainly a utility there. But when we start using them, like Susan mentioned, off-label for the use of behavioral and psychological symptoms of dementia for more than 3 months, or for insomnia, that's when we start thinking, these are our patients who we want to get off of them. So the first two symptoms that I mentioned here, the BPSD and the insomnia, are really our candidates for deprescribing. So number one with all of these drugs is, who can I deprescribe? Identifying is usually the easiest part. It's how do I do it? That is the hard part. So really, how you can do it is you tell them this. You tell them the evidence for improving these behavioral symptoms is really poor. It's likely not going to help them. It may reduce aggressive behavior, but most of our patients aren't truly aggressive to the point of hurting themselves or others. We really need to think about who is the particular patient that would benefit, and a majority probably wouldn't fit into this category. There is thought that it may reduce caregiver burden and that there's a small impact in that, but actually caregivers have reported that they believe that their family member or the person they're caring for has improved quality of life when antipsychotics are not used. So it's the opposite of what we think. We think, oh, I'm helping you out by reducing your caregiver burden. But actually, when we take off the drug, caregivers think their quality of life seems better. So that might be one thing that you can teach your patient or their caregiver about antipsychotics. And really, when it comes to insomnia, really just poor efficacy. And just to throw it out there, there's essentially no drug out there that has good efficacy for insomnia for the long term. And everyone wants that magic pill. And the answer is sleep hygiene and cognitive behavioral therapy more than anything else. And figuring out what is the underlying cause of that insomnia and treating that if we can. And Susan mentioned already, there's tons of side effects to antipsychotics. So teaching your patient, teaching their caregiver, whoever it is, that there's metabolic symptoms related to cholesterol and potentially increasing their risk of having diabetes, worsening their A1C, gaining weight, all of these things. In your patients who have severe dementia, weight gain is usually not our biggest concern. But in other patients, that can be a reason to get off of these medications if we're thinking about insomnia. EPS symptoms are not uncommon. Falls and fractures, somnolence, and those anticholinergic effects. And like Susan mentioned, increasing the risk of death and cerebrovascular events. And there is a black box warning. So feel free to show your patient or show their caregiver, whoever's caring for them, there is a black box warning right on your drug for patients who have dementia, because these medications increase the risk of death and cerebrovascular events. When we think about tapering, again, you're going to hear the same things over and over. Reduce by 25 to 50% every 1 to 2 weeks. And I would honestly suggest, again, the slower the better. That way you're making small incremental changes. Don't change any other drugs at the same time. And really think about are they having changes in their symptoms? You can, however, discontinue without tapering if it's being used for insomnia. I think about low-dose quetiapine or Seroquel being used for insomnia. You can just stop that drug. You will, however, probably get rebound insomnia, but it's nothing that won't go away within a couple weeks. And consider attempting twice. So you may find your patient is failing the first time. Try it again. And I know that that sounds really frustrating. Try it again. It's not going to work. It's worth a second time because, again, going back to what Susan said, right drug, right person, right time, and right dose, all of those rights need to be in order. And it could have been one of those rights was wrong in the first time. So withdrawal symptoms, typically we don't have that many if you do it nice and slow, but there is, of course, the risk of rebound insomnia and psychosis, aggression and agitation, if those were what we were treating in the first place or attempting to treat behaviorally, and delusions and hallucinations. Again, if that's happening, I'll go into how we can treat that because it certainly does make it more complicated. So for our antipsychotic algorithm, there's actually a really nice one on Deprescribing.org as well that you can use on your own time. So I'm not going to run you through it, but I think the one thing I would mention here is giving your patient or their caregiver that information. And I would say slower. Slower than 25% if it's possible. Go with the next possible dose, half those tabs if you can. Most antipsychotics can be split in half. When it comes to monitoring, like I mentioned, you really have to monitor those symptoms. And I would say every week would be the minimum at which we need to check in with our patients. If you're in the nursing home with your patient and you can check in with them every day, even better. But recognizing there's going to be fluctuations and a weekly review is probably a little bit better than the day-to-day changes that we typically see with dementia anyway. When it comes to management of worsening BPSD, if we have to, adding back in an antipsychotic. So in this particular case, aripiprazole or Abilify, olanzapine, Zyprexa, or risperidone or Spiridol, all would be preferred. They have overall less anticholinergic side effects at lower doses. So using the lowest possible dose if you must. And then again, consider trialing off again if you can. And then of course, non-pharmacological approaches, which I think that Susan did a really good job of reviewing and you've reviewed in the past. So this is really kind of beyond my scope, but if we have to, non-pharm should be the way we go. And then when insomnia, really we're thinking about sleep hygiene, like I mentioned, and then pharmacotherapy, really avoiding benzodiazepines and non-benzodiazepine hypnotics, which are our Z drugs like Ambien, because for the same reason I already mentioned, we don't want these meds on board, especially with our patients with dementia. What we can try is melatonin and really non-pharm focuses. If you really felt the need to get something in terms of objective findings, every week or every 2 weeks, you can do the Cohen-Mansfield agitation scale if you feel like you want to objectively assess. The Deprescribing algorithm and guideline for antipsychotic reduction and Deprescribing recommends this as a tool if you need something objective to look at to see if your patient is changing significantly each week and getting worse. And now the last section, I included the hardest section for the very end, which is our anti-dementia drugs. And there's a number of reasons why these are so hard, but really it's the conversation around them that makes it so difficult. So for the most part, and Susan already mentioned this, studies supporting the efficacy of these drugs are really limited, and most are only 6 to 12 months in length. And I think someone did comment while Susan was talking that, you know, you see a benefit for about 1 to 2 years, and anecdotally I do too, and then it seems to plateau. And when we see a benefit, we're not seeing this improvement in cognition. We're seeing delayed nursing home admissions. We're seeing improved activities of daily living, cognition a little bit, and neuropsychiatric symptoms more so, and really delaying the symptom progression. And what I like to say here is we're improving our symptoms, but we're not altering the course of the disease. The disease is progressive. It will continue to, cognition will continue to decline, activities of daily living will continue to decline, we can't stop it in its tracks, but we can try to reduce that as much as possible, as well as the other symptoms that are associated with dementia. So who is our candidates for deprescribing? Again, this is complicated, and I'd argue that most patients who are on it for more than a year really should consider a trial off if they haven't seen much improvement. So whether you're on a cholinesterase inhibitor for a year or memantine for a year, that should be your indicator. This is my patient, I need to think about deprescribing. We need to have this serious conversation with a caregiver. In terms of deprescribing indications, these are our typical indications. And like Susan mentioned, a lot of drugs are used off-label. So if your patient has any type of dementia, really, we should be thinking about deprescribing if we're not seeing these benefits. And so specifically, you're on it for a year, you have some type of dementia. And I bring that up because cholinesterase inhibitors can be used for things like myasthenia gravis. So we don't want to stop it in those patients. You get symptomatic benefit. But cholinesterase inhibitors and memantine use for dementia is our category. And really in those who are getting significant worsening of their cognition or functional status over the last 6 months. So in the last 6 months, asking your patient or their caregiver, are we seeing improvements? Is it actually getting much worse? People who are seeing no benefits and they're not seeing improvement, they're not really seeing stabilization or decreased rate of decline. And those who have severe end-stage dementia, where activity of daily living, they're completely dependent on for all of those activities, those are our patients where there's no evidence to prove that continuation or initiation, for that matter, is going to impact our patients. Other rationales that are going to help you make a decision with your caregiver, like I said, the stopping the medications is the easy part. Identifying your patients is the easy part. Talking to your patient and their caregiver about stopping these drugs is the emotionally taxing, difficult part. So thinking about, has mom or dad stopped their medications in the past? They're refusing to take drugs. They're not adherent. If that's the case, it's not safe to start a drug, stop a drug, stop. That's hard on them physically. That's not safe for them long term. If your patient or caregiver or family is making the decision, then albeit it's up to them ultimately to come off these drugs. Drug and drug disease interaction. So if your patient is on other drugs that have cholinergic effects, if they have anticholinergic effects and they're completely going against what the cholinesterase inhibitors are doing or what memantine, while working a different pathway, is trying to do, or medications that cause bradycardia, for example, with your cholinesterase inhibitors. Those are all drug-drug interactions we should be worried about. Drug disease interactions, someone who has underlying bradycardia, those would be our patients who probably should come off of the drug because it could be exacerbating the condition. If they're having severe agitation or psychomotor restlessness, those patients are not going to benefit from a cholinesterase inhibitor or memantine if it's very severe. So that might be a talking point as well. And then let's say they have a non-dementia related terminal illness. This again is going to be up to the patient and their caregiver or their family, whether or not they so choose. But if we think about the time to benefit of a drug and a patient has already been on maybe one of these drugs for years, they're probably not going to get significantly more benefit. And if their life expectancy is now suddenly shorter than expected, that would be a good time and a good trigger to have this conversation. So how do we deprescribe? And again, you're going to see it 25 to 50% every 1 to 4 weeks. But what I like to say is just go by the possible doses available and do it every month. So send out a month's supply of the next lowest dose if you can, and check in with them every 1 to 4 weeks, however you feel comfortable, depending on your patient and what kind of care they're getting at the home. So I mentioned here, I have a list of all the drugs that we typically use. So donepezil, galantamine, rivastigmine is oral and a patch. So you can do it both ways. And then Namenda or memantine. And so these are drugs that are available currently in the US and the doses that they're available. And so just going from one dose to the next is a perfectly reasonable way to dose adjust. And then on the last rightmost column, I have their half-lives. And I include that because you want to kind of think about what is 5 half-lives. So that's about the amount of time it takes for the drug to be completely cleared. And I use air quotes here, cleared from the body for the most part. Of course, this changes if you have reduced clearance, renal clearance or hepatic clearance. but not drastically in these particular patients. So about 15 days. So when you stop the drug at the end, so when you go from 5 milligrams to 0 of donepezil, waiting about 15 days will get an idea of how is this person without the drug in their body at all. And then after 15 days or so, give or take, assessing what's going on with them. Deprescribing.org, again, has really great algorithms for deprescribing, cholinesterase inhibitors, and memantine. And they go through very simply, like, who is our actual candidate for deprescribing and who is not our candidate for deprescribing. And they go again with that 12-month mark with those who are really not benefiting. And they go through all of those categories I already mentioned. In terms of monitoring, this is really big. At minimum, I say every 4 weeks. There's essentially no reason why we need to go and monitor them less, especially if we're giving them month supply. I really encourage at least 1 to 2 weeks after a dose reduction, because you're looking for worsening cognition. That can certainly happen. When you stop the drug or reduce the drug, you can get this very short period of worsening cognition, and it feels like mom or dad just sort of dropped off, and now the cognition is so much worse, and they're going to want to start the drug back up again or increase the dose again. But just checking. And so worsening of functioning, physical functioning, or ADLs, we want to worry about, and then withdrawal symptoms. So after 3 to 7 days, we're thinking about hallucinations and agitation, any changes in GI symptoms. So cholinesterase inhibitors typically cause those wet symptoms. So is your patient now having constipation? Are they having changes in their appetite affected by the actual drug coming off? And Namenda itself, when we think about, or memantine, when we think about withdrawal symptoms, there aren't much, but there are some case studies that shows that when patients are abruptly stopped from their Namenda, they can have worsening agitation and aggression. So that's another reason why we really want to reduce all our anti-dementia meds very slowly. So how do we manage withdrawal symptoms? You can restart if you need to at the lowest effective dose and see if these symptoms are getting better when you restart, or if there are really no changes. If there's no changes, go ahead and pull the drug off again. And then in the very rare setting in palliative care, we may consider an antidopaminergic agent. So thinking about our antipsychotics, very rarely, if the situation fits the bill, if we're in palliative care and we can do the lowest effective dose, this is sort of our last case, our last line option. And again, talking about these things, so what we need to do when we're looking at dementia medications is we need to have the conversation very bluntly with our patients and our caregivers about their benefits. So, what is the benefit for their particular disease state? For how effective is it? How long is it going to be used for? What are the life expectancy benefits? And then potential harm, so adverse drug reactions, which are very common with these drugs. All of those interactions with drugs or disease states, and then pill burden or cost burden. These are all really simple things. What I would do with patients is I sometimes write a list. What are your pros with this drug? What are your cons with this drug? And, can we meet in the middle and think about stopping? I think for the most part, deprescribing dementia drugs is driven by the patient or the caregiver and not as much by the provider, but we can offer them so much information when it comes to dementia care and specifically dementia medications when it comes to rationale for deprescribing, because there's a lot. I've given you a lot of reasons. And so I'm going to just end it on some additional tools. I already mentioned deprescribing.org. If you see this big blue screen, you made it to the right place. Right over here, under resources, there's resources dedicated to patients, caregivers, but also clinicians. And so that's where you'll find algorithms. You'll find anecdotal stories from patients who came off of drugs and are feeling better. And then all the guidelines are there too. And then MedStopper is, and this is where I remembered Doug Danforth's quote here. MedStopper is a really interesting tool. It's been in the beta mode for as long as I've ever used it, which has been the last 5 or so years. Basically, you indicate that your patient does, in fact, fit a frail elderly category. All of these recommendations are based on a patient being frail and elderly. You type in the drug, you can type in the generic name or the brand name, and then it'll ask you to pick an indication for that drug. And that will look like this. So for example, if I put in metformin for type 2 diabetes, aspirin for a previous heart attack or stroke, and atorvastatin for the same indication. And it uses these silly happy faces, which are kind of funny and kind of silly, but I think they're useful when we look at them with patients. And my big thing with this, if I haven't made it clear, is I always include patients very clearly on every type of recommendation I make in terms of the benefit and the risk. And so if I had a patient in the office with me, I would pull up their med list with all their indications and bring this up for them to show them how I would prioritize dose reduction or deprescribing in general. And I wanted to go through this again, but actually just the other day when I was going through it, all of their images are like broken, so you can't see the color block. And so the darker the color, the higher the priority for deprescribing. And then you can't see the happy faces. So the person that I am, I've already reached out and let them know that their content isn't working quite so well. But I wanted to do this for like donepezil or an antipsychotic for BPSD, but I wasn't able to. But it's very nice. It links you to nnt.com, which is the number needed to treat.com. They link you to essentially a review of a drug for that particular indication. It is not the biggest repository of information, but it's available. And then they link you to whether or not the drug is a Beers or Stop criteria drug. So with that, I am going to stop. I think I went over my time, but I see lots of questions, so let's stop for questions.
Hi there, can you hear me?
Yep.
My name is Karen Demetris. I'm a geriatric doctor at Maine Med. This was really helpful. Thank you. For me, it's pretty straightforward to stop the dementia medications in people who are dependent on others for ADL care. But what's a little more gray is when I'm thinking about stopping a dementia medication in somebody who's still living in the community, because I've experienced the rare situation where I stop the medication, cognition suddenly worsens, and then I reinitiate the medication, and then cognition never reaches its previous baseline.
Yep.
And so, this is not something that's mentioned in the literature. It's just sort of anecdotal that my more experienced colleagues have told me about, and then I unfortunately experienced it myself. So I guess what I'm saying is I'm still hesitant to withdraw memantine and donepezil, even though there's an obvious decline. Can you help me through that conundrum?
Yeah. And I would say some of the strongest literature on utility of these drugs is delaying progression to institutionalization. And if your patient is in the community, that is the hardest patient group to reduce a medication, because there is a chance that the cognition goes down, the functional status goes down to the point that they now need someone to take care of them for their ADLs. So I think that you're in the right for your patients who are community bound, not community bound, that's the wrong word, who are community dwelling, because the ultimate goal is to see if they can age in place. And if a drug is doing that, and if your patient isn't getting worse, and if I'm hearing your question correctly, let me know if I'm interpreting it wrong. If your patient is still in the community and isn't requiring ADL dependence, then continuing the drug actually makes quite a bit of sense. Now, if they're suddenly having terrible side effects, they have no appetite, they're nauseous all the time, they have diarrhea, they're losing weight, that would be an indication to reduce. If their ADLs are going way down, and they're thinking about institutionalization, well, maybe that's a time to reduce too. But ultimately, if you can keep them in the community, I think you're very much in the right for not wanting to reduce, because we just don't have the evidence yet that, and we see it anecdotally, when we reduce these drugs, we do get that sudden decline in cognition. And you're right, it tends to not go back to the baseline it was weeks before when they were on the drug. I think everything you said is completely right. So when we think about deprescribing, again, it's our patients who there's a clear risk that's outweighing the benefit, and it has to be patient specific. If the benefit is my mom or dad or whoever is staying in the home and that works for my family, then that's hard to compete with.
Thanks, Sydney. And thank you for that question. I have nothing to add on the Katie's comments, and nothing to add on your answer. We have about 6 questions. We have about 15 minutes. And Sydney, I wonder if I could ask you to stop sharing your screen.
Yes.
So that we can see one another, as we have for people who want to, can go into gallery view and see the respondents. Someone simply made an observation about seeing an increase in Haldol use and in the hospitals. I didn't know if there was a question related to that. I'm not working in a hospital currently, and so I don't know if others are seeing that. If that's a concern. Does anybody want to talk about Haldol? I don't have any more information on it.
So Sydney, on your, I love your aging brain care chart, and I actually have laminated it when I was a fellow. Haldol actually has an anticholinergic score of 1. So I like to use it particularly, in hospice patients, or because it's not sedating, and it doesn't steal consciousness in people who are terminally ill. I mean, it does carry significant cardiovascular risk because it's an old antipsychotic, but it's actually not as bad as Seroquel in terms of its anticholinergic effects.
Correct. Yeah, absolutely.
You know, I would agree with that about the anticholinergic effects, but one of the problems as a psychiatrist in practice for a long time with Haldol is that the muscle stiffness and the bradykinesia is really, from a patient's perspective, even it is as burdensome as the anticholinergic. And that's one of the problems right along with Haldol, is that it's got this very favorable anticholinergic profile and a really lousy EPS profile, right? So it's always trying to trade that off for the particular patient. We have a question from Drusilla about Ativan for anxiety. Sydney, I think you can see it there. A family member had been taking Ativan for a long time. And Drusilla asks how to help him get off his nightly routine.
Yes, I feel like this is the classic picture of what I see all the time. So, and I didn't mention it before, but I work in family practice. So I see really all folks from all walks of life. But predominantly what I get consulted on is benzodiazepine deprescribing, because when I came into my clinic, I had a weird amount of experience deprescribing benzodiazepines, and I've been doing it for the last 5 or 6 years. As long as I've been a pharmacist, I've been doing this. So there's no easy way. The key is you need to get, and it sounds like it's a family member, you need to get your family member on board with the downsides of benzodiazepines. And something that I think really works for people is saying, did you know that there's an association? It's not super strong, and you can use the language you want to use. There is an association between benzodiazepines, like the one that you're taking, and changes in your memory, and even dementia. And when people who are older adults hear dementia, it makes them very fearful, is my experience. I try not to use those terms too strong. I do like to remind people you can have changes in your memory. Here's the biological thing. It causes retrograde amnesia. Then I describe what retrograde amnesia is, and then I remind them that they're taking it every day. So the rationale that you could have memory impairment is very clear. So that's usually one thing I do. Another thing I do is, other than actually printing off the Empower brochure, is I send people to what's called mysleepwell.ca. It's a Canadian website. And I'm sorry, I have a high affinity for Canadian resources, because they have been doing deprescribing way longer than us, way better than us for a very long time. And, I'm a US citizen and I like the work we do, but we are literally decades behind Canada. So it's called My Sleep Well. I'll type it in the chat. I believe that's it. And this is just a nice website for people to explore. when I'm having patients who don't want to stop, I just say, go ahead, explore. Like if you're using it for sleep or anxiety, go ahead and learn a little bit more. It's kind of like the Empower study, but boosted with more information. It's more blog-like, and there's sleeping diaries that you can use. It talks about cognitive behavioral therapy. It actually talks about how not useful these drugs are for sleep in a very patient-friendly way. So that is my go-to.
Thank you very much. Sydney, a couple of questions here around marijuana use. And I was surprised to hear somebody say that they have a resident who's gaining access to marijuana. Not that I was sorry, but many nursing facilities, in my experience, have been very reluctant because, of course, there is a federal prohibition on using marijuana. I'm not going to call out anybody for using it, but marijuana is a very interesting drug, I think. And I wonder if you could comment on its use, I think here, particularly in agitation, in not otherwise specified in dementia. What's been your experience with it, Sydney?
Well, this topic came up a couple years ago, right as medical marijuana was used a little bit more. And I remember the topic being that we would all be talking about was, can we use it in older adults? Is there a risk of cognitive impairment? And so there isn't a clear answer. Medical marijuana doesn't just act on a cannabinoid receptor. It acts on tons of receptors all over the body. And if it was a drug that was in a pill, I would call it a dirty drug, because I think about it like some antipsychotics that act on serotonin and dopamine and anticholinergic and antimuscarinic. It's all over the place. Medical marijuana is the same way. And because of that, it's really hard to tell who is going to benefit from what dose at what time. One, THC is directly associated with psychiatric symptoms, so like delusions, and more like paranoia. But in patients who have dementia, I would steer clear of high dose THC if you possibly can. And so now that we live in this new world where you can get medical marijuana, and there's high dose THCs and low dose THCs and high CBD and low CBD, I would say the CBD approach would probably be the safer approach when we think about side effects. Now, efficacy, there's almost no clear-cut data on whether or not it works. So it's got to be totally dependent on that patient. If you told me your patient took this dose every day, and since then they haven't been agitated or aggressive, I would say, great, keep doing it. What is long-term benefit and risk? We don't know. But if that keeps them from being on an antipsychotic, if that keeps them from going on a benzodiazepine, that's perfect. Those drugs are so much worse. We don't have black box warnings around medical marijuana, and I don't know when we will, if we will, for what. But antipsychotics are rough drugs in the body. And so if we can avoid them by a small dose of something that is a little different, that might be the way to go. But again, I would say it's got to be individual, because right now we just don't have the data to support it.
Great. Another question here, Sydney, is, and I'm not quite sure of the wording of this, and the person who asked it may want to speak up, but asks if it's fair to tell patients that drugs with anticholinergic burden increase their risk of dementia. I don't know if it meant to say it seems to me fair not to. I mean, it wouldn't be fair not to. So I'm not sure exactly how the questioner intends it. But is it fair to tell patients that drugs with anticholinergic burden increase the risk of dementia and increase the risk of more rapid progression? And so I guess, my question would be, why wouldn't it be? It seems to me for informed consent for any of these medications, we're always informing people of the risk and the possible benefit, and why, if our recommendation is that they endure the risk, what our reason for that is. Do you see this question differently, Sydney?
I can see it on both ends of the spectrum, actually. I can see how it can make someone pretty aggravated to learn that a drug they've been on for years actually is now associated with dementia or worsening MMSEs or delirium. The delirium is a little bit more clear-cut. That's, we can stop the drug. That feels okay. We can deal with this. what I get all the time, I get this with opioids, benzodiazepines, and I get this with anticholinergic drugs, is why didn't you tell me before?
Mm-hmm.
And the answer is we didn't know before. We just didn't have the data. And so trying to be really show your empathy when you can with this, because your patient is getting blindsided by this information. And while this seems so obvious to us, that is not what is out there. There are no commercials on TV saying your oxybutynin could increase your risk of dementia. No one is telling them that. And it's up to us to tell them. So from one side of the spectrum, it is totally up to us. It's not fair to not tell them. On the other end of the spectrum, your patient is going to feel blindsided. They are going to be angry probably about it. And so, letting them know this is what we've learned and now you're showing symptoms. And when we're younger, we don't have those symptoms quite as much because of XYZ, like what I mentioned before, changes in our physiology. And my go-to is I tell people every single day we age. It doesn't matter how young you are, how old you are, we age every single day. And the change in our aging changes our ability to take the drug, absorb it, metabolize it, excrete it. That's going to change with age, and it changes individualistically. So using all of those terms in any particular order is the way to go. But yeah, I can see the question from both directions.
I asked the question because I say it very directly to lay people that XYZ causes dementia, but it's actually an association. It's not really a causative relationship. So it was more of an ethical thing. It's hard. I don't have the time or the finesse to describe the difference between causation and association with my patients. But I guess I was just wondering, it sounds like you feel comfortable with me being very strong and provocative in my language, counseling patients and their families. So thank you.
Yeah. And I will say my students hate this, but I always tell them nothing causes anything. So causality is essentially non-existent. It's always an association. If you have to use the word risk, high risk, that's the easiest, I think, term.
Rebecca, you had a question about schizophrenia. Would you like to just say it verbally?
Hi. First, I just want to thank you both. This has really been wonderful. So I'm on kind of the other side of things. I'm a clinical psychologist, so we deal with things behaviorally. CBT is our go-to. And so there are cases in which, patients have chosen that the antipsychotics are worse than the symptoms that they're experiencing. And so I'm thinking of one case in particular in which, it's a woman who has a long decade history of untreated schizophrenia, but the hallucinations and the delusions are manageable. They're able to use self-talk and those types of coping strategies. But now with age, they're starting to become more prominent. And, the PCP is, really encouraging them to, get on antipsychotics, but they're also starting to have some cognitive aging issues. And so I'm just wondering, in this type of situation, when there is a history of psychosis, that's been able to be managed, and then we start to see it worsening with age, and there seems to be a push to want to put patients on antipsychotics. What can be kind of said, in those situations?
I would say, Rebecca, that in those situations, unlike the situation with dementia, with psychosis, you have somebody with a condition for which this is an FDA-approved drug. And you have a class of drugs that are actually really good at treating what ails them. And that's the advantage to working with people with schizophrenia, for example, as opposed to people with dementia with psychosis. So in my view, a drug trial is absolutely warranted at the lowest possible effective dose, with a clear target symptom. I'm sure you've seen this in your practice. I've treated a lot of people with schizophrenia whose hallucinations don't bother them a bit. they can live with them, and they work and they live and they love and they play, and they don't need to be on an antipsychotic. However, when those hallucinations turn angry, or when they become delusional, or when, as you say, they have a thought disorder and it really interferes with both their functional abilities and their quality of life, then I think the trial of an antipsychotic is always warranted. I'm old-fashioned. I still like risperidone. I have never had occasion to switch to like the newest atypical, and very low dose risperidone is a great way to go, with careful targeting of the symptom of interest that really is interfering with life, and then monitoring for side effects. I don't know, Sydney, what do you think?
I completely agree. I would say, yeah. And risperidone, perfectly good antipsychotic to start with. You can go really low, really slow, and just seek what is the lowest effective dose I can use in this particular patient, because it is FDA approved, and unlike dementia, you actually will get a very clear benefit from it. It won't be so wishy-washy. So I think there is some utility in if it's something where you feel like the patient is declining a little bit more now, could this keep them in their home longer or keep them without skilled care?
Thanks so much, Sydney. It is 12 o'clock, and I know some people are sending thanks and goodbyes in the chat box. And Sydney, I'm so delighted that you joined us for this final installment of Dementia Reconsidered, and we will be hitting you up next year. People are already asking, why not CMEs? And if we do it again, we would love to have you back. Thank you all so much for coming. Questions we didn't get to, Dr. Springer and I will look at them. And if we can offer a short and sweet answer and we have your email, we will do that. Again, thank you for coming, and look for future editions of Dementia Reconsidered, brought to you by Aging Maine. Take care.
Thanks.
Thank you both so much.
You're most welcome.